Welcome to another insightful video in Ocular Surface Gurukul, where this time we dive deep into limbal stem cell deficiency. Limbus is an annular transition zone between clear cornea and opaque sclera. It houses unipotent limbal epithelial stem cells responsible for the steady state maintenance of the corneal epithelium and its regeneration following injury in the basal layer of crypts of palisades of Vogt. These stem cells divide to give rise to one daughter stem cell that remains in the crypts to maintain the stemness, and one transient amplifying cell which migrates to the basal layer of the corneal epithelium, proliferates, and moves centripetally and anteriorly, differentiating into terminally differentiated cells which are eventually shed off. X plus Y equals Z, and this maintains the normal corneal epithelial homeostasis. LSCD can thus be defined as a disease caused by decrease in either the population and or the function of epithelial limbal stem cells, which leads to inability to maintain the just described epithelial homeostasis. Additionally, limbus, through a delicate balance of pro and anti-angiogenic factors, acts as a barrier to the blood and lymphatic vessel growth, maintaining the avascular state of the cornea. Loss of this barrier leads to conjunctivalization and neovascularization of the cornea, affecting the clarity. To sum up, limbal stem cell deficiency primarily and essentially leads to disruption of the epithelial homeostasis and loss of the limbal barrier function. Coming to the clinical characteristics, spectrum of the disease may vary from a dull light reflex, ill-defined limbus, and loss of transparency in the early stages to encroachment of fibrovascular tissue on the cornea in the moderate cases, to recurrent or persistent epithelial defects with corneal scarring in severe cases, to finally a fully conjunctivalized surface in patients with total LSCD. Coming to the etiology, LSCD can be caused by a variety of factors, which can be primarily categorized into acquired causes such as trauma, infections, inflammation, surgery, radiation, and medications, and hereditary causes which include various congenital conditions and genetic mutations. The common causes, though, include chemical and thermal burns and immune-mediated diseases like SJS, OCP, VKC, and GVHD. LSCD can be diagnosed through a combination of clinical evaluation and diagnostic tests. The presence of conjunctival cells on the cornea, a location where they do not normally belong, is considered the hallmark of LSCD and forms the basis for all diagnostic modalities. This can be done by collecting corneal samples through impression cytology and detecting the presence of core blood cells through various stains such as H&E, GIMSA, PAS, or by identifying conjunctiva-specific cytokeratin markers like CK7, CK13, and CK19 using immunohistochemistry, using in vivo imaging modalities like confocal microscopy, which can detect core blood cells and loss of the limbal architecture along with the other corneal changes, and ASOCT, which shows a non-specific epithelial thinning. However, these imaging modalities are expensive, not always available or accessible in every clinic, and have limitations in accurately staging the disease. Clinical examination with slit lamp biomicroscopy remains an easy, reliable, and reproducible method for diagnosing and classifying the disease, making it the perfect approach in many clinical settings. The Global Consensus Group has classified LSCD into 3 stages, primarily based on the involvement of the central 5 mm of the cornea and the degree of limbal involvement. Let's understand how this works. If the central 5 mm zone is spared, it is stage 1. This is further classified into A, B, and C depending on the degree of the limbal involvement. 1A if the limbal involvement is less than 180, 1B if it is more than 180 but not 360, and 1C if it is 360. When the central 5 mm is involved, it becomes stage 2, which is further categorized as stage 2A if the limbal involvement is less than 180, and stage 2B if it is more than 180. Stage 3 is when we have a total corneal surface involvement, that is total LSCD. So, with this background, let's dive deeper and look at some case scenarios. Case 1. A 38-year-old male with a history of chemical injury. We can see pannus encroaching at two focal sites. It's a focal LSCD. What is the stage? Any guesses? Let's have a look at it. Is the total corneal surface involved? No. Is the central 5 mm involved? No. So it becomes stage 1. Degree of limbal involvement less than 180. So it is stage 1A. Second case is the case of recurrent pterygium. Any guesses for the stage? Let's look. Is the total corneal surface involved? No. Is the central 5 mm involved? Yes. So it becomes stage 2. Degree of limbal involvement less than 180. So it becomes stage 2A. Case 3. We can see that almost 70% of the corneal surface is covered with the pannus. Let's put a stage. Is the total corneal surface involved? No. Is the central 5 mm involved? Yes. So it becomes stage 2. Degree of limbal involvement more than 180. So it is stage 2B. Get along. Try and guess on your own now. Case 4. Superior pannus and corneal haze. Stage. Keep that in your mind. Easy peasy, right? Case 5. Another case of chemical injury with the toilet cleaner. Note that stage down. Case 6. Corneal neovascularization. Stage. Is it an LSCD though? Keep that in your mind. Let's stain and assess all these cases again. Staining with sodium fluorescent strips and cobalt blue light can differentiate corneal from conjunctival epithelium. Corneal epithelium is transparent with bright light reflex, tight impermeable cell-to-cell junctions, and so does not take up any stain. Conjunctival epithelium, on the other hand, is thinner, translucent with dull light reflex, leaky cell-to-cell junctions, and therefore takes up the stain which persists in the late phase. Let's stain and assess the case 4 now. Did you get it right the first time? It's stage 2B, as only a small central island which is not taking up the stain is the corneal phenotype. Rest entire surface has conjunctival phenotype of epithelium which takes up the stain. Look again. What was the stage that you chose for case 5? Let's see if it remains same after staining. No staining, corneal phenotype. Stain take-up, conjunctival phenotype. Demarcation, which is well appreciated with cobalt blue light and yellow filter. Central 5 mm involved, limbal involvement more than 180, making it a stage 2B. Coming to case 6. How many of us think that it's not an LSCD and just a corneal neovascularization because of some other etiology? Let's see. Staining makes it pretty evident that it is an LSCD and a total LSCD, as the entire surface is covered with the conjunctival phenotype, which makes it a stage 3. Not bad. You are getting a pro at it. Let's try the next one. Next case is of a 30-year-old female who was a chronic contact lens user, came for a regular checkup with complaints of occasional discomfort. On careful examination, had a superior limbal haze. Let's stain and check. Here we have a pattern of alternating columns of stained and non-stained areas. Metaplastic conjunctival epithelium taking up the stain, alternating with corneal epithelium, which does not take up the stain. This pattern is termed as columnar epitheliopathy, which is an early sign of LSCD. Next case is of a 9-year-old boy, bilateral aniridia, a congenital condition which is known to be associated with LSCD. There is no vascularization or pannus on the diffuse photograph. Is there any limbal involvement? Let's stain and confirm. What do you see? That's correct. We have interspersed areas of conjunctival and corneal phenotype. A limbal stress pattern, again a sign of early LSCD. Another similar case, bilateral aniridia in a 22-year-old male. Guesses for the stage of LSCD? That's correct. It's a total LSCD. The entire corneal surface is covered with the conjunctival phenotype. It's a stage 3. Any intervention, medical or surgical, in such patients should be planned cautiously and meticulously. This is a flowchart guiding to stage the disease. We offer a short-term clinical fellowship in ocular surface disease. Details regarding the same are on the screen. Please feel free to reach out if you have any questions or if there is any specific topic you would like us to cover. Thank you for your patient listening. We hope you enjoyed watching. Until next time, take care and stay tuned.